Hello, everyone. Thanks for joining. I'm just make sure my volume's up. Oh, not up. There we go. Thanks for joining me. I am going to be joined here shortly by Dr. Sekhon, a reproductive endocrinology and infertility specialist. So I'm going to wait for her to join. So give us a few minutes. Let me know if you guys can hear me okay. Just give me a thumbs up. Oh, there she is. There she is. Ooh. View request. Play-Doh. She should pop up here soon. Hello.
Hi.
You're a little, oh, wait, here we come. Here you go. You were frozen for a minute, but I can hear you. So hopefully you'll unfreeze here in a second. There you are. You were frozen.
How's it going?
Doing well. I actually have a vacation day today. So
Oh my gosh, that's amazing.
I know. There's nobody in the house, just me and the dog who's right here on my lap. So
What are
yeah.
you going to do with your amazing vacation day?
Well, the twins will be home in an hour, so probably it's over after this. Yeah, it's after this.
Got it.
All right. So I was just introducing you. Dr. Sekhon, reproductive endocrinology and infertility specialist. Tell us where you are and where you are on social media.
So I'm based out of New York City. I work at a practice called Reproductive Medicine Associates of New York. We have several different locations throughout the city, and we're a fairly busy IVF clinic, but we do a lot more than just IVF treatment for patients. You can find me on social media. My handle on Instagram is @lucky.sekhon. I also have a personal blog where I like to put a lot of useful information, frequently asked questions for my patients. It's called www.theluckyegg.com.
Yeah, and I've shared some of her blogs underneath my highlights too. So I will share her blog in my stories after we're done here, so you guys can take a look at that.
Awesome,
okay, but
thanks.
we're going to dive right in because I have a lot to go through. I don't know if we'll get through that. There's going to be another part too, I'm sure. But let's just get started. The first question I have is why, and we're going to answer this in two parts. Why is age 35 considered advanced maternal age? You start first from the fertility aspect, why it's considered advanced maternal age.
Yes. So I know that everyone thinks about this dreaded number. A lot of women come to me like right before their 35th birthday, and they worry about what that means for their fertility. I think a lot of patients envision that there's this cliff, and once you turn 35, you drop off of it, and your fertility is just in a bad place. And that's actually not true. There is a notion that fertility starts changing more rapidly at 35 and older, and that's why we use that cutoff as kind of a marker. The main issues are both the quantity and the quality of your eggs change over time. When you think about what goes into fertility, establishing a healthy pregnancy, there's so many different components, right? There's the male side, sperm health, your reproductive tract, making sure your uterus and your tubes are healthy. And then there are your ovaries and the eggs they contain. And that is really the only major time sensitive factor. And it's because we're born with all the eggs we're ever going to have. You can't make new eggs. You can't repair or fix your eggs over time like other cells in your body that can be repaired or regenerated. And so both the quantity and the quality are changing. Quantity, a lot of people fixate on. They come to me and they worry about what their egg count is going to be because they just turned 35. And I tell them it really has no bearing on your reproductive potential, how many eggs are there. Every woman is releasing a single egg, usually most cycles. And so it's not a numbers game. The reason we as fertility doctors care about numbers is because it tells me how easy it would be to treat you if I have access to a lot of eggs at one time. But what's really more important about your natural fertility and aging is the egg quality issue. And there's no test for egg quality. And when we talk about quality, what we're really fixated on is the genetic content of each egg. Every embryo, every person who's healthy should have 46 packages of DNA or chromosomes. And 23 are coming from the egg, 23 are coming from the sperm. The fact is we tend to ovulate a lot of eggs that are not providing that 23 packages of DNA, meaning an embryo forms that doesn't have the right amount of DNA. And the most common thing to happen is it just won't implant. Or if it implants, it might stop growing after the fact, and that's a miscarriage, right? So that is a problem that becomes more prevalent, more common as we age. If I was to take all the eggs from a 20-year-old from their ovary, turn them into embryos, and then genetically test those embryos, even then about 20% of those embryos are going to be abnormal, right? And that's as good as it gets. But by the time you're getting to 35, you're looking at rates of about 30 to 35%. And once you get to 40, it's more like 60 to
Yeah.
70%. That's what we see when we test in our clinic, because a lot of patients doing IVF are testing their embryos now. So we have this data. So that's the key issue that is linking age and why it's harder to get pregnant on your own naturally after 35. But it's not impossible. It's just that you're more likely to ovulate an abnormal egg the older you are.
Right. And the reason why 35 is the key for me as a maternal fetal medicine specialist is because way back when we were starting to do amniocentesis, which is the diagnostic test to look for what the chromosomal makeup is of the baby in your uterus, we found that at age 35, the risk of having a baby with Down syndrome was roughly equal to the risk of the complications of having an amniocentesis. So that meant that after that, the benefit or the information you could get from an amniocentesis after age 35 was kind of in your favor, and we would encourage that more so after age 35. So that became why 35 was the magic number for us. Anyone over age 35, whether they, for whatever reason, is entitled to an amniocentesis if they just want to know. They don't have to have something wrong or something wrong with their screening testing or anything like that. But if the amniocentesis is the only way to definitively know for sure what the genetics of your baby or your pregnancy is, unless you do CBS, but that's the cutoff for that is around 10, a little bit over 10 weeks. Whereas an amniocentesis can be done from 15 weeks on. So that's where it came from our standpoint as being maternal fetal medicine specialists and obstetricians, why 35 is the number for us. There was I just published a post the other day about, was it the national statistics, what they give on births, and the average age of the first time mom is actually going up each year. So we know that we're having more and more women who are older, especially in the over 40 age group, that are having babies is increasing. But that still means that especially if you're conceiving spontaneously, that still means you have to or need to assess your risk for having a baby with a genetic abnormality. So that kind of in a nutshell is why 35, geriatric pregnancy, advanced maternal age, those very, very sexy terms we call you.
That's geriatric.
That's where they came from. I know. I don't know. It is what it is. Geriatric is kind of offensive, but
Yeah.
what can you do? All right, let's go to this. And this is for you. How does fertility decline? And you already addressed this a little bit. Discuss how fertility declines after age 35. For example, just kind of put it in terms of your chances of conceiving per month at 25, 30, 35, 40, and like what does that look like? If month to month, what are your chances of conceiving at age 25 and then as you get older?
For sure. So bottom line, human reproduction is inefficient, right? Even in your 20s, when you're considered to be in your fertile prime years, each month you have about a 20% chance of conceiving, right? And once you get over 30, and these are very general terms, obviously, not considering specific tests and things that you could do on a person, but in general, that falls to about 15 to 20% in your 30s. At 35 and older, you're looking at rates closer to 10 to 15% chance of conceiving each month. And then once you approach 40, it's generally as low as 5% per month.
And then that's just conceiving. That's not taking into account a successful pregnancy or a take-home baby, right?
Right. Exactly.
So that's just conceiving, right? And then the numbers are going to go lower than that when you think about having a successful pregnancy and a take-home, what we call a take-home baby. But that's just your natural, their chances of conceiving spontaneously with your age.
Right.
Okay.
And that's because the rate of miscarriage increases as you age, right?
Right, of course, yeah. Okay, so I want to talk a little bit about antenatal screening for chromosomal disorders. Everyone is entitled to some form of antenatal screening, and there are tons of tests that are available. What is offered to you may depend on what your insurance covers. The non-invasive prenatal testing or non-invasive prenatal screening, which is a form of cell-free DNA screening where they do the blood test. They extract some DNA from the fetus. They send that DNA. We need a high enough fetal fraction from that blood sample in order to get the genetics of the baby. It typically looks for the sex chromosomes and then trisomies 21, 18, and 13. There are some NIPTs that can look for other things, but that's probably won't be covered by all insurances. What insurances typically cover, it's looking for those 4 things. What people have to understand, because the NIPT is very popular because it is giving you the sex chromosomes as early as 10 weeks, okay? And I get it. It's still a screening test. It is not diagnostic. So it either is reported as high risk or low risk. If it is high risk for any of those things, an amniocentesis is going to be recommended to confirm. It is your choice as to whether or not you want to pursue that. Now, the same thing can be said for any screening test. If you have any antenatal screening test for chromosomal disorders and it comes back positive or high risk for anything, the diagnostic testing is going to be most often the amniocentesis, and that's up to you whether or not you want to pursue the diagnostic testing. But again, it's your choice, and you have to remember all of these things are still screening tests. The other thing I was going to say about the NIPT, if you are over age 35, what is getting recommended, and I think is going to be happening, I do it myself, is if you're over age 35 and you want the NIPT, great, that's fine, but I'm also going to recommend a nuchal translucency screening with that. That screens between 10, it's dependent on the length of the crown rump length, but it's roughly between 10 and say 12 weeks and a few days, 13 weeks or so. The amount of fluid on the back of the baby's neck, okay? No additional blood work, but those two together is starting to become recommended for those of you over age 35. And why is that? Well, we can look at the genetics based on the cell-free DNA testing or NIPT. This gives us an indication of the genetics as well, but it also for other things like heart defects and other fetal defects of the anatomy. Okay, so those two are going to be, if not already, going to be done together in persons over age 35. Antenatal screening is optional. It's optional, and I get it. I highly recommend it, and this is the main reason why. What I see all too often is they decline it doesn't matter what's wrong, if there is anything abnormal with my baby, and that's fine, so they decline the screening test. Then they come in for the anatomy test or anatomy scan. We might see an echogenic focus, echogenic bowel, something that's considered a minor marker. We might see a cleft lip, and then we're going to offer additional testing for you. If I don't have that screening test, I'm talking in general terms rather than giving you a numerical assessment, which a lot of people understand numbers a lot better. You have a 1 in 2,500, a 1 in 25 risk of having a baby with genetic defect. So that's really where that antenatal screening comes in. Choosing to have antenatal screening does not mean you would terminate your pregnancy. The best thing it does is it helps for counseling in the future if you need it. Does that make sense? Is that a good way of explaining it? It really helps us to counsel you if we were to find something abnormal on the anatomy scan of your baby that's typically done at 18 to 22 weeks or so. So that's why I'm a big fan of it. Obviously, that's what I do. But I hope that it explains the antenatal screening in a nutshell. Do you have anything to add to that?
I think I'm of the mindset that getting more information is always better, right? And I think a lot of times patients worry about tests and what the results are going to show because they automatically assume that it means they're going to have to take some sort of action. But I think just being mentally prepared to know what to expect.
And I agree, and it has it's no reflection on what you would or would not do with your pregnancy if you got that test. Right. A lot of people do it just for the information.
I see it all the time with fertility patients. I see male partners who don't want to get a semen analysis because they're worried about what it might show, and same with the female partner. So I think more testing is better in a lot of ways, just getting more information and being educated about your body.
And it's a lot easier to counsel patients if it's needed when you have that information. So it's much more helpful for me to be able to counsel the patient in a more succinct and have it make more sense when I have that additional information. Okay, here's a good one. I get this question all the time. Egg freezing after 35, and especially after age 40. Let's talk about first, when is the best time? If you had someone that came to you and asked you at age 18, and they said, when would be the best time to freeze my eggs, the optimal time? What would you say? And then answer that question first, and then talk about those of us after age 35 and especially age 40, is egg freezing worth it?
Right. This is such a loaded question, but I love it. It's very important. So I think that it depends what your goals are, right? If you know that you're someone who will definitely want to freeze your eggs, no matter whether you're going to come back and need to use them in the future. And what I mean when I say that is that not everyone who freezes their eggs has to use their eggs to get pregnant. That's a common misconception. Yes. You can always try on your own, and they're kind of like a backup option. If you have trouble getting pregnant and you come to a fertility doctor like myself and push comes to shove and we think, listen, you might need IVF. Instead of going through the stimulation of IVF and extracting your eggs at that age where you're probably going to have fewer eggs and the quality may be compromised compared to when you were younger, we could dip into your supply that you froze when you were younger, and your likelihood of success from that treatment cycle will be higher, right? So that's how it's typically used as a backup option. So if you know that you're 100% going to freeze your eggs and you don't care if you're going to come back and use them or not, then the earlier you do it, the better, because you're going to get more out of one cycle. What I mean when I say that is the number of eggs that you have, right? You have millions when you're born, well, hundreds of thousands to a million when you're born. And by the time you get into menopause, you have less than 1,000. And every month, I'm not able to access those types of numbers as a doctor. All I'm able to get to is a subset that is randomly pulled to the surface of your ovaries. And your brain selects one to ovulate if you're someone who ovulates, and then the rest die off. When we're doing egg freezing or IVF, what we're able to access is that random subset that's pulled to the surface, right? So all I'm doing is basically accessing that because it's going to get thrown out anyway. So it's salvaging. And as you lose eggs over the course of your lifetime and you have less eggs overall, you're pulling fewer to the surface. It's like a rationing process. So if you know that you want to freeze your eggs, the younger you do it, the more I'm going to be able to access in one round. And a higher proportion of those eggs that turn into embryos are going to be healthy.
Normal, yeah.
So the answer is the younger the better, but people hate that answer, right? There are some patients that really don't want to do it because it's expensive. It's a lot of work, right? And it's effort. And if you knew that you had a crystal ball and I could tell you that you're definitely going to get pregnant, no problems, then you wouldn't do it, right? So if your goal is to try to only do it if you think that you're going to need it, there have been some studies that have been very clever in modeling out what the probability is that you would actually need to use your eggs. And so, you know, I think doing it between 35 to 37 was deemed the most cost-effective time, meaning your odds of maybe needing to rely or use those frozen eggs go up, right, beyond age 37 because of egg quality issues that kind of crop up over time. So it's probably more likely to be useful at that age, but the younger you are, the more you're going to get out of one cycle. And the costs are not going to differ according to how many eggs you get from a given retrieval. So, you know, you're going to get more out of it, whether you're thinking of the financial investment, the emotional investment, the physical process of going through the whole thing. You're just going to get more out of it the younger you are. So there's no right answer. But I think, you know, the goal is always to have as many eggs as possible. The two most important factors that dictate your chance of success when coming back to use frozen eggs are how old you were when you froze your eggs and the number of mature eggs frozen. And both of those are going to be better the younger you are. Now, egg freezing, I could talk about this for an hour, but I'm not going to because we have a lot of other topics. But in general, the thing to know, and I think a lot of people are starting to know more about this, is that if you freeze 10 eggs, that does not mean you're going to have 10 children, right? There's a lot of inefficiency. Just like we said, every month your chance of pregnancy in your 30s might be like 10 to 15%. Why is that? Because not every egg that you ovulate is going to get fertilized. Not every fertilized egg turns into an embryo. And not every embryo is normal and will find the right spot in the uterus to implant. Same thing happens with egg freezing. You're freezing potential, right? But when you go to thaw out those eggs, not every egg is going to survive the thaw. The majority should, and the younger you are, there are some studies that show the younger you are, the more eggs will survive the thaw. But ask the clinic you're doing this at what their rates are, right? And I would tell you our average rate for all comers is maybe around 85% surviving the thaw. So you're going to lose some eggs in that early step. When you look at egg freezing and just general IVF data, anyone who's gone through an IVF cycle knows this. Not every egg is guaranteed to fertilize. 80% is our average, right? And ask your clinic what their average is. And then about 60% of fertilized eggs will turn into an embryo a week later. And then depending on how old you were when those eggs were frozen, that's going to determine what percent of those embryos are genetically normal versus abnormal. And normal embryos don't always implant. 60 to 65% of the time they do. That's why I give rough numbers, but based on guessing what someone's egg quality might be at a certain age, I'll say, for instance, you know, if you're between 30 and 35, having 10 to 15 eggs frozen puts you in a very comfortable position, right? But this is kind of a guessing game, and there's a lot of question marks and unknowns at each different stage. How many are you going to lose? And so that's why the more you have and the better the quality is as judged by your age when you froze your eggs, the better of a situation you're putting yourself in.
Now, I always tell people, you know, if you're thinking about it, there's probably a reason why you're thinking about it, right?
Right.
And one of the ones that's most common now is delaying childbearing for career choices or whatever other choices. So if you're already thinking about it, you might want to consider doing it, because
Right.
there's probably something in your life for whatever reason that's making you think it's very likely that I'm going to be starting a family after age 35, maybe even after age 40. And if you're already thinking about that, just do it.
Right.
That's what I say.
And I mean, there's lots of data out there that shows egg freezing outcomes start to decline more rapidly at
Yeah.
38 and older, right?
Yes. Mm-hmm.
And I always tell patients who come to me at 38 and older wanting to freeze eggs, that's what they come in for. They oftentimes leave with a completely different idea in their head, because
Yes.
I'll say, the advantage of egg freezing is freedom,
Mm-hmm.
flexibility to be able to have children with whichever
Yes.
partner of your choosing in the future, right? And it's
Mm-hmm.
open-ended. That's the main advantage. Otherwise, the medical advantages all lie with embryo freezing, because you've already
Mm-hmm.
gotten past all that drop off. You know exactly what you have to work with. Especially if you genetically test those embryos, you'll have a higher degree of confidence that they're healthy and have reproductive potential. And embryos thaw out much better.
Mm-hmm.
98% is our thaw
Mm-hmm.
survival in our clinic, and
Mm-hmm.
most places have similar rates. So
Mm-hmm.
if you have embryos frozen, you have a high degree of confidence you're going to be able to come back and
Yeah.
use them.
Yeah.
The downside is you can't unfertilize them.
Yeah.
So for
Yeah.
patients who it's more important that they have a child from their own eggs, they may choose to use a sperm donor
Yeah.
and create embryos so they can actually genetically test the embryos and freeze them.
Yeah, yeah. And just one other cautionary tale, and I don't mean to scare everybody, but it happens. I have a good friend who's about 7, almost 8 years younger than me, and I knew she was heading down the same path I was, as far as, very, very career committed in a very demanding career, not in a relationship, and it was kind of writing was on the wall that she probably was going to be around my age when I started wanting to have a family, and that's exactly what happened. I did convince her, after several years of talking to her, to freeze her eggs. She froze her eggs between 38, almost 39. She got 6 eggs to freeze, which is not great if you think about the stats that Dr. Sekhon just went through, especially at her age. She met somebody at 40, going to get married. They decided to, all those eggs make embryos, and unfortunately none of them were genetically normal. I think out of the 3 survived the thaw, if you will, and then they were fertilized, and none got to the testing phase. So it does happen, and I do think that if you're freezing your eggs, it's best to do it before age 37, like Dr. Sekhon said, but the earlier the better. Just think about why you're thinking about that. And another thing you can do is go to someone like Dr. Sekhon and have this conversation with them, because they're so good about making you think about things that you might not have thought about before, and give you more scenarios and more stats to help you, empower you to make that decision as to whether or not you should proceed. So this is what they do every day, and they know how to have that conversation with you.
And a lot of patients come to me very nervous because, again, they feel like making the consultation means they're committing to egg freezing. And that's not
Yes.
true.
Yeah. And I say this every conversation I have with a fertility specialist. Seeing one of these guys does not mean they're going to stamp IVF on your forehead. They're going to stamp you with egg freezing and put you on the conveyor belt. They are very good at counseling patients about the best approach for them. They're experts at counseling and talking about this. So if anything, just going and listening and having that conversation like, we just had, is so beneficial for you. And it's really empowering, and it can help you make that decision. Okay, next thing, and I get this question a lot too. If someone went through IVF, they had PGS, pre-implantation genetic screening, and got chromosomes of the embryos, then they got pregnant. Do we still need to do antenatal screening on those embryos?
So I think that every patient who has done pre-implantation genetic testing on their embryos to count the number of chromosomes in the embryo should pretend that they never did that, and
Once they're pregnant.
Start with a blank slate.
Yep.
The reason I say this is I think it's a great technology. I use it on a lot of my patients, but there are drawbacks. What we're doing is you have an embryo, right? You have 100 to 200 cells. Some are clustered in the center. These become the baby. And then the ones that line the periphery, those become the placenta one day. So all we're doing, because we don't want to harm the embryo, we're removing very few cells from the part of the embryo that becomes the placenta, not the baby, right? And the accuracy rates have been well studied. They're about 98%, but it's only as accurate as the cells that are being sampled. We know that in biology, you can have embryos with different cell types running through it, right? It's called a mosaic. And it's a normal part of early development. And some of those abnormal cells that might not have the right number of chromosomes die off, and then the normal ones might win out, and it turns out to be an overall normal embryo. So you're just getting this small sampling, and it might not be representative of the entire embryo and the eventual pregnancy and baby. So I don't ever want someone to leave my clinic when I'm discharging them between 8 and 9 weeks. I always tell them, pretend you never did this testing and listen to whatever your doctor has to tell you about offering all the range of screening and diagnostic tools, because this may not have sampled everything that there is to know about this embryo. Also, there is an error rate of about 2%, right? And so I think there's also limited resolution. I'm only going down to 5,000 base pairs, 5 million base pairs of DNA. So there might be small snippets of DNA that are duplicated or missing that could have clinical consequences. And you want to have that full range of options, and don't close yourself off to genetic testing, because there is more that can be looked at.
Right. And then, and along the same lines, I'd use donor egg. So when I did the antenatal screening in my pregnancy, the only difference is that when they put in the age, they put in the age of the egg donor, not me. And that's where the risk is assessed from. So I still did antenatal screening. I did not do PGS testing on the embryos that I got from my donor egg, because she was my donor because she was 25 or so, 24, 25. But when I did do the antenatal screening, her age was put in instead of mine. And you can qualify that on your antenatal screening. But I still did the testing. So that's the only little bit difference if you use donor eggs. But the same is not the same if you use for donor sperm. They don't ask the age of the sperm. For sure.
Exactly.
It's only the egg. Okay. All right. Now here's going to be a good question. And I don't even know if I'm going to ask it, because people are going to ask. All right. Ovarian Reserve. Okay. I know, you're going to know. Ovarian Reserve and AMH. People get so hung up on AMH. Just talk first about what is Ovarian Reserve.
Yep.
And how can it be tested? What's the most efficient way? If you did your test for Ovarian Reserve at 30, can it change at 33? And can it change again at 35? Does that make sense?
Yes, totally.
Okay.
So we started this conversation talking about the eggs being the only major time sensitive factor in fertility. And we focused first on kind of the quality and the genetics of the egg and the resulting embryo. But the other time sensitive factor is the quantity of eggs that you have, right? And that's going to determine overall how many get pulled to the surface each month, because if you have a lot of eggs stored up, then you're going to pull a lot to the surface and throw out a lot every month. And if you have few, then you're going to pull only a few to the surface, right? And that's why it really matters for treatment. But when it comes to ovulating an egg every month and trying to get pregnant, you're only really ovulating one egg every month. So it's not a numbers game. So your ovarian reserve is important to know for the purpose of treatment and how many eggs we can access, not trying on your own. But it is important to know where you stand. And unlike egg quality, egg quantity can actually be looked at on an individual basis. I'm not putting someone in a bucket with every other patient that's their age and making assumptions. I can actually measure directly by doing an AMH level, which is a blood test. Anti-Müllerian hormone is basically a hormone that is produced by all the little cells that line each bubble of fluid that has an egg floating inside of it. Those are called follicles, right? So the more AMH you have, the more follicles you have, the more of those eggs have been pulled to the surface. So it all correlates with each other. The other thing that I can do is do an ultrasound and count. I can actually visualize those bubbles of fluid and see how many eggs got pulled to the surface this month. And if I see at least 8 or more, that's considered normal. But I hate speaking in thresholds and binary, because that's just a stupid cutoff that, that's what's written in the textbook. But really, you have to look at the whole clinical picture. If I see a 20-year-old with 10 at the surface, I'm like, that's kind of low for someone who's 20. But if I saw a 40-year-old with 10 at the surface, I would say that's actually pretty good.
Great.
So it has to be taken into the context of who you are, how old you are, what the situation is. But there are 2 tests that we can do in an individualized way to figure out where you're at in a relative sense. Do you have a high reserve? Is it low, or is it average? People really fixate on this because it's the one thing we can test, right? Now, I said that it really only matters for treatment, but I kind of lied, because I also think that it is interesting and something to keep in the back of your mind. If you're 30 and for some reason someone tested your AMH level and it's 0.2, what does that mean, right? I can't tell you what that means for the future. Like your AMH level today and your egg count today.
It's at that point in time, right? It's at that point in time.
At that snapshot in time. I can't tell you how fast you're losing your eggs, right? And I can't tell you when you're going to go into menopause. Many studies have shown it's not a good predictor for that. And it's definitely not a good predictor for your chance of pregnancy or live birth trying on a monthly basis. So, you know, the reason I say that it might pique your interest and it would be something you'd want to keep top of mind, because, you know, if that person with an AMH of 0.2 in their early 30s has a family history of premature menopause, you know, you just have to kind of think through things logically and think, am I catching them on that trajectory where they're losing eggs faster? I don't know. And there aren't good studies to really prove whether that's the case. But someone might say, okay, this might get low. I know I'm not going to gain eggs, right? And if I'm losing eggs all the time, even if I'm losing them slowly, if I'm already at this low level, you may want to freeze your eggs because, you know, just out of an abundance of caution. And it might be harder to freeze eggs once your levels are that low, because I'm only going to have access to few eggs in a given cycle. So I think it's a complicated discussion, but don't shy away from, you know, having that discussion. A lot of people get it tested and then they just freak out. But I think if you actually talk through what it means.
So basically, I think the key take home in my mind, and I'm not a fertility specialist, so I will represent the average person, is ovarian reserve can only tell us the potential egg quantity that we have, not the quality of the eggs, right? It is a snapshot in time. You take that number in conjunction with what the number is, what your family planning goals are, what your age is at the time that's done. But we cannot say, okay, your AMH is 25,000. I'm making it up because it's a high number at 32. And that's good for, you have at least 4 years to conceive. We can't do that. It's not like we can say your AMH is great, so you have 4 years to conceive. So you have to understand it's for that time period. If you are considering maybe freezing your eggs, getting that number, and you might have a lower number at a younger age, you might want to consider freezing your eggs a little bit earlier or younger, right? Or if you are considering delaying childbearing and you don't have a great AMH and you're in a position to potentially start a family, you might want to make that decision to start a family a little bit earlier. So the AMH and ovarian reserve is not an absolute. It doesn't tell you about everything, because you have to consider all these other players in the game, right?
Exactly.
And there's so many players in the game. And whereas I think when people talk to me about AMH, they just see the AMH and they're tunnel visioned, and that's all they can think about. But when there's so many other things that are involved that help that AMH make sense. It's not just a number, right?
And the same way we use this kind of arbitrary cutoff of more than 8 follicles, and you have normal ovarian reserve and below is diminished. The cutoff for AMH tends to be 1 or 1.2 nanograms per milliliter. It's important to look at the units because different countries will report AMH in different units, which can be confusing. In your history, the family history, if you have a history of premature ovarian failure or early menopause, all those play into what the AMH means. There's so many things that play into what does that number mean. And then people get confused by FSH too. I think it's less helpful of a marker just because it's often not tested at the right part of your cycle. But if you're not on birth control and you get regular cycles and you're able to get tested on day 2 or day 3 or day 4 of your period, then a high FSH usually means that you also may have diminished ovarian reserve. And that's confusing to people, but what it is it's a marker from your brain. And a high level means it's basically whipping your ovary and trying to get it to produce estrogen. And if you have a low egg count, that FSH level is going to be higher because it's more work to try to push the ovary to do its job.
And as Dr. Sekhon said, it's important when the FSH is done. It can't just be randomly done. I hear that all the time. There is an optimal time period to have that done, and having also not being on birth control is important as well. So keep that in mind, because I know people get that drawn all the time, and does it mean anything because either they were on birth control or recently stopped, or it wasn't drawn at the right time. And it's even more problematic.
It should be drawn with the estrogen level.
And that's even more important to know. So this is another reason why the reproductive docs are important, because they know all this is what they do every day. So getting that, talking about that too with someone who can interpret that. And then there's a lot of times where I hear that FSH AMH was drawn and then the doc that drew it didn't know how to interpret it. we as physicians, and I'm just going to get on a little bit of a soapbox, we should not be drawing any lab that we cannot interpret for the patient. If someone is doing that for you and then they say, I'm not really sure what this means, that's a problem. They shouldn't have drawn the lab. They should send you to somebody that knows how to interpret the lab results if they're not comfortable doing it. Enough on that topic. Okay, let's see. Okay, here's another good one. IUI versus IVF after 35. I put that in because I got a lot of questions about that, but my experience with people messaging me about this is, and why I want to have this conversation about IUI versus IVF is this. Number one, I have heard of patients going through a gazillion IUI cycles that are not successful. And then they say they spent all of this money, and then they say, I should have just gone to IVF.
Right.
And I want to address when to do IUI versus IVF, especially after age 35. Who to do it with. I think general obstetricians are good. Some are good if this is what they do it routinely. IUI is fine, but you know, I do have a personal opinion on how many cycles should be done. But again, I'm not a fertility specialist. I just don't want people to get into that place where they spent all these thousands of dollars on IUI and still have not been successful. And then their nest egg for whatever money they had to use towards fertility treatments is gone.
Exactly.
So what say you?
Yeah. So a lot to cover here, but just in general, for people that aren't familiar, IUI, intrauterine insemination, is basically taking a washed semen sample and injecting it with a long, thin, flexible catheter at the top of the uterus. So if this is your uterus, I'm going to do a lot of hand signals.
Yeah.
So basically, if this triangular shaped uterus is here, your tubes are here, and your ovaries are here, right? So we're just injecting the sperm at the top. Normally, it would have to swim from the vaginal canal. And so it's not really changing the game that much over just timed intercourse around the time of ovulation. If you're doing it in a clinic, whether it's with your OBGYN or a fertility doctor, it can be helpful because they'll also help you time when we should be doing the insemination, right? And maybe they'll pair it with medications, especially couples with unexplained infertility. We don't know why they're not getting pregnant after 6 or 12 months of trying. Everything checks out on testing. We're just basically gambling. We're doing things on the egg side. We might give you medications, oral pills like Clomid or letrozole that give your body the opportunity, not the guarantee, but an opportunity to release multiple eggs. Instead of just working with that one egg, which seems like a long shot when you think of all the things that it has to go through to get to a healthy pregnancy. Now, if you release 2 or 3 eggs, well, we're upping the odds that one of them will turn into an embryo and stick, right? And on the male side, on the sperm side, what we're doing with the IUI or the insemination is we're concentrating, we're washing the sperm, and we're injecting it closer to the top of the uterus, closer to where the eggs are being released. So it really is gambling. It's not precise. You're just trying to improve the chance of the sperm-egg interaction and hoping for the best. So that's why the success rates reflect that, right? It's like a 5 to 10% max improvement upon your baseline chances, right? And couples who have been trying on their own for, let's say, an entire year and they haven't been successful and all their testing's normal, we usually would think, okay, but just statistically speaking, your chance of pregnancy each month thereafter is like 5% maybe. So maybe it gets you to like 15, max 20%. So you have to go into this treatment approach with the mindset of don't expect the first one to work. I always tell that to my patients, and it sounds really negative, but I say, I don't want you to be devastated. You have to go into this with the long game and be persistence will pay off, but sometimes it won't. So when do you call it, right? And when I say call it, I mean move on to something more successful. There's 2 buckets of treatment. There's this type of laid back approach that I just described with the IUI versus something much more precise where you're taking control of as many steps as you can, IVF, right? IVF is different. You're taking injectable medications to try to get as many of those eggs that got pulled to the surface that are available that month. You're trying to get all of them because they're all going to get thrown out anyway. So you're trying to grow them, mature the egg, and extract the egg. That's a procedure that happens after 8 to 10 days of shots. Vaginally, a needle is put through the vaginal wall directly into the adjacent ovary, and we're draining all those bubbles of fluid to pick up the eggs. The egg and the sperm are put together directly. Either a bunch of sperm is dumped onto each egg, or if there's severe sperm quality issues or other reasons to do this beyond the scope of our conversation, you can actually inject each sperm directly into each egg. You're growing them in, media that is nourishing the embryo and giving it everything that it could need to grow and develop. You may genetically test the embryo at that stage. You have the opportunity to do that. You can't do that if someone's doing an IUI. It's all happening in their body, right? So you can actually determine the number of chromosomes in each embryo. Then you can freeze them. So it is completely different because we know that if we put a genetically normal, healthy embryo at the top of the uterus, really the only guesswork is the embryo going to implant, right? So 60 to 65% of genetically tested high quality embryos may implant and result in a live birth in a really good lab, right? And so the success rates are very high. You get pregnant faster. The time to pregnancy is shorter. You have the option to do genetic testing, especially if you're older and you're concerned about your risk of miscarriage. It will reduce your risk of miscarriage, right? Because you're ruling out the number one cause. If you only put back one embryo at a time, your risk of twins or multiple pregnancy is going to be lower because the embryo can split, but that's really rare. It happens like 1 to 2% of the time. With IUI, if you're releasing multiple eggs, the risk of twins or higher order multiples like triplets, twins is generally between 3 to 8%, right? So it's different in risk. And also with IVF, if you have multiple embryos that are created, they can remain frozen, the ones that you don't use. And so that's the key. If you're over 35 and you're worried about your timeline, right? To have a child, to recover, to wait an appropriate, safe amount of time, which we should talk about, for the next pregnancy, you're probably going to get to like 37, 38 before you have the ability to get pregnant again, right? And your chance might be lower then. So for patients who over the age of 35 definitely want 2 or 3 or more children, I strongly advise them to consider IVF even up front. I did that myself, by the way. Because, you know, it gives you the opportunity for fertility preservation. I think if you're going to do IUI and you're over the age of 35, I generally speaking say, you know, after 3 IUIs, let's sit down and have a conversation. Doesn't mean you have to do IVF, but let's talk about it.
So your timeline and your financial resources also play a factor. And we don't have to go into all that, but you know, what your timeline is, what your financial resources are is important because you have to consider that, and also what links you're willing to go to either take out loans or take out extra money for these fertility treatments. You know, thinking about that sooner than later is ideal because then you could say, you know what, after 2 IUIs, after 3 IUIs, I need to proceed to the next step. And that can help you make more of a plan because you have to plan. I think anytime someone starts approaching the path of using assisted reproductive technology techniques, all of those, IUI, IVF, all of it, you have to come up with a plan, not just financially speaking, timeline speaking, emotionally speaking. It's to me, it's necessary because you have to know to what lengths you will go and under what time period. And it's something to keep in mind. And you mentioned
insurance will say we will cover IVF, but you have to do IUI for first, 3 rounds. And I've had some patients that are like, well, I'm 36 and I know I want 3 children. So I actually hope I don't get pregnant with these IUIs because I would love to just freeze embryos, but I obviously want to do it when it's covered.
And that's another factor. Your insurance might dictate to some degree what you're able to do as well. Okay, you mentioned interpregnancy interval or pregnancy and birth interval. So I'll talk real quick about that. So an interpregnancy interval means the time from birth of one child to conception of the next. We do not recommend a time period of less than 6 months. Those shorter birth intervals, interpregnancy intervals, have the worst outcomes as far as preterm birth, potential infant mortality, and having complications in the pregnancy. Ideally, we would rather you wait for 18 to 24 months. But if you can't, then ideally 12. Now, that's also going to depend on if you had complications in your pregnancy, if you've had multiple C-sections. You know, all of that it does play a factor, especially if you're over age 35 and you are on a timeline. But you do need to have a conversation with someone about that. And one thing that I've heard a lot is the person who has had 1 or 2 C-sections. Talking to your doctor at the time, listen, I want to get pregnant soon. What is your recommendation based on what you saw in my belly? How long should I wait to get pregnant again? I have given patients that information because I went in after 1, 2, or 3 C-sections. There was scar tissue, a uterine window, a uterine dehiscence, anything like that. And I'm going to tell them, listen, you need to give your uterus as much time as possible to heal before you try to get pregnant again. And I try to do that anyway, even if they don't ask. And I even try to put that in an op report as much as possible if I saw something like that. but not all docs are going to do it. So you have to consider stuff like that. I think ideally no less than 6 months between birth of one child to conception of the next. If I had my druthers, at least 18 months. But if I had to negotiate a little bit, no less than 12 would be ideally, both for you, the health of you, the pregnancy, and the neonate. The pregnancy interval, interpregnancy interval does matter. Do you have anything to add to that?
So I follow those exact guidelines. Yeah. I do get a lot of pushback sometimes from patients because especially my patients who are older, they are, focused on what it's going to be like to go through another pregnancy. They worry about the complications associated with age and pregnancy alone. But I always tell them the incremental risk of, being 41 and a half versus 42 in terms of your risk of high blood pressure, diabetes in pregnancy, or any of the other things that happen as a result of age is not really that much of a consideration as I think the additive benefit of 6 additional months. Instead of doing it 6 months after delivery, 12 months, you're going to really lower your risk.
Yeah. I mean, it's important. And if you have a question and you're on the fence about it, you can do preconception consults are so good. You can do preconception consults with fertility docs like Dr. Sekhon and myself, maternal fetal medicine specialist. So we can look at the whole picture. And sometimes we'll even work together and I've had REIs send me patients for a preconception consult because they might want my opinion especially if the patient's older, about what the potential complications might be because of their age. So there's no reason why you can't do that. We do that all the time, and insurance should, for the most part, I've never had a problem with it, does cover preconception consults. So take advantage of that if you have any questions. Okay, here's a good question. When is amniocentesis recommended? So amniocentesis, like I said at the beginning, is an invasive but diagnostic test that we do. We take a needle into the belly. The earliest we typically do that is 15 weeks. And the reason for that is you want the amnion and the chorion, which are the 2 layers that surround the amniotic sac, which the amniotic sac contains the amniotic fluid. They are separate up until 15 to 16 weeks, then they fuse. If they're still separate and you put a needle into it, the chances of breaking one of those sacs is greater. So we wait till the amnion and chorion are fused before we do the amniocentesis. You could also do a CBS, which is earlier in pregnancy, but I'm just going to speak on the amniocentesis right now. Why do it? Anyone over age 35 is entitled and allowed to get amniocentesis for no reason based on age alone. The other reason why you might do this is because your screening was abnormal. The NIPT, the quad screen, anything like that, you can get it done as early as 15 weeks. And the reason why that is important is because the anatomy scan is typically not done until 18 to 22 weeks when the baby's big enough for us to see as much as we can. So waiting till we have that anatomy scan to add that additional information to a positive screening test might be too long, in your opinion, or for you to wait. So you might want to decide to do the amniocentesis just because you had the positive antenatal screening for whatever reason. Some people decide to wait if they've had an abnormal screening, to get that anatomy scan. They put what we saw in the anatomy scan with what the screening test was, and then they make the decision on whether or not they want to get the amniocentesis. But the thing to remember is that you're further along in pregnancy. So that will take away certain options that you have for your pregnancy if you do wait, but that's completely up to you. And that's a conversation that should be had with you and your physician. Genetics counseling is also important to utilize them too, if that's to help you make your decision on whether or not to do the amniocentesis and when. So that's generally when to do an amniocentesis. Or if you've had positive screening tests, negative screening test, then we went to do the do the anatomy scan, and we saw something on the anatomy scan: a heart defect, a cleft lip, cleft palate, multiple abnormalities, multiple minor markers like an echogenic focus, echogenic bowel, something in the brain. We might see things that further increase your risk of having a baby with a chromosomal defect. Then we might recommend the amniocentesis. So those are in a nutshell, why an amniocentesis might be recommended. Finally, one other thing: if you have a genetic history, you personally, or an increased risk of having a genetic issue known in your family, that could be another reason why we could do an amniocentesis. Okay.
Something that's emerged from our field, actually, and I don't know how much of this you're seeing as an MFM, is when we do the embryo testing, the resolution of the technology has gotten so good that now we can get really granular, and it's not just, oh yes, it's a normal embryo, or no, it's abnormal. And you can have kind of a patchwork where some of the cells are normal and some are abnormal. It's a mosaic. And I know that that's not a really common thing, but I think it's going to become more common. We are transferring mosaic embryos in cases where patients really can't make another embryo. They have diminished ovarian reserve, or they're older, or they've exhausted how many cycles they can do. We may consider, with extensive genetic counseling, you can put back this mosaic embryo because there have been live births and normal, healthy children thus far. But in those cases, we always tell the patients, you should absolutely get an amniocentesis.
Yes. Okay, one more question, then we're going to answer some questions here. Let's see. Okay, here's a good one. If someone is approaching age 35, when should they see a fertility specialist? After how long of trying to conceive spontaneously? When is it time to see someone like yourself?
So the textbook answer is 6 months, right? But I would say it's never wrong to come sooner. Reasons to come sooner: if you don't have regular cycles, you should absolutely see me sooner, because if you're not having a regular cycle, it means you're not ovulating regularly. And if you're not ovulating, you're not in the game, right? And it's hard to time when you should actually be attempting. If you have a known history of any gynecologic issues, like if you know that you have fibroids and it's been identified, why not just check in sooner to make sure those fibroids aren't in a location that is going to make it difficult to get pregnant or increase your risk of a miscarriage? If you know you have endometriosis, right? If you have any sort of background medical condition, or even a family history, let's say where multiple family members have had multiple miscarriages. If you're concerned about anything like that, just come in sooner and have a conversation.
Yeah, I think the whole thing about, when to see a fertility specialist, it starts with, what are your menstrual cycles like? And if you're over age 35 and you're not having regular monthly menstrual cycles, like Dr. Sekhon said, you're getting further and further from the game. So we got to first figure out why you're not. And I think some people don't, what's the right word? They don't understand the significance of having regular menstrual cycles.
Right.
That is essentially saying that you're ovulating regularly. And if you're not, or you're regular sometimes and sometimes you're not, or you'll go 30 days and you'll go 20, that's not regular. So it's important to establish what your menstrual cycles are, especially after age 35, because that does help you kind of determine when you're going to see someone sooner than later.
Right. And just to learn more about how your body works and how you should even be trying.
Yeah. Okay, well, I have about 10 more questions. We're not going to get to those, obviously, so we're going to have to do a part 2. But let's go through and see what some of the questions are here. Let me see. How does Clomid assist in ovulation? Well, what is Clomid? How does it work?
So Clomid is a pill, and the way we use it is we usually tell patients to take it for 5 days, right? And what it's doing is it is blocking a receptor in your brain. So there's this whole pathway. What does it take to ovulate? Let's talk about that first. So basically you have those eggs that are pulled to the surface of the ovary in that given month that you're in, or a given cycle that you're in. And your brain actually sends signals to the ovary. And the first one to respond to that signal, it's almost like a lottery, is the one that gets selected to ovulate. And then the rest of them die off, right? But your brain is also picking up signals coming from the ovary. And so if it doesn't detect enough estrogen, just like the FSH level, those levels are going to be increased if your estrogen levels are low. So Clomid fools your brain into thinking there's not enough estrogen in your body. And your brain ends up churning out a stronger signal. So if you're someone who just doesn't ovulate regularly, either because, well, most often because the signals are being sent, but they're just not being received appropriately. Think about it like a game of broken telephone in your ovary. The signal's getting dropped. Well, now if you give yourself a medication that strengthens that signal, well, hopefully it will overcome that communication blockage and finally get you to ovulate. So it can get you to ovulate regularly if you don't. It is also used for women who ovulate regularly, but we're just trying to boost their chances. Remember the gambling we talked about with the IUIs? I'm going to try to make you release more than one egg. So with a stronger signal, you might be able to achieve that. So that's how it's used. It gets a bad rap because, some patients have symptoms, but I have a lot of patients that don't have any symptoms with it. Hot flashes being the number one. But that's basically how it works. It can either make your cycles regular if there aren't, or it could just boost your chances.
Okay. All right, next question. Do the abnormal eggs result in chromosomal disorders, or is it not viable? So a couple of things. The abnormal eggs, it could result in either. It could result in no successful pregnancy, no, conception is not successful, or if it is, it could also result in a miscarriage. And then even sometimes if the pregnancy progresses, it could result in a genetically abnormal fetus. So there's no real way to tell which one of those things is going to happen. And there's no way, nothing that I've ever heard of that tells you what causes one to happen. Meaning, if you have an abnormal egg that gets fertilized, what makes it not result in conception? What makes it result in a miscarriage? And what makes it result in a genetically abnormal fetus? We don't have that kind of information, and we can't tell you what the chances are of each. We just know that genetically abnormal embryos will likely lead to one of those three circumstances. Right. Does that make sense?
And there's only a handful of those types of errors that are compatible with a live birth. Right? Like, because it depends on what chromosome's missing. Some have genes that are critical. You cannot have an implanted embryo if you don't have those genes. So it just depends where the error happened.
Right. Yeah, I think Laura Jen was saying, I think this is a response to the AMH, FSH. She thinks that sometimes they cause more anxiety than necessary. Would you agree that getting those tests is, if there's a reason to get those tests? I hear a lot of people, I'm just going to check and see where I'm at. Maybe there's nothing wrong with that, but I think that if the results come back not like what you expected, it is going to cause a lot of stress and anxiety, right?
ASRM, the American Society of Reproductive Medicine, we follow their guidelines, and they're very strong with this. They say unless a woman is attempting conception or, testing their fertility for a specific reason, it's not something that should just be done for everyone, which I agree with, and I understand the concerns. But being the type A person I am, putting myself in the patient's shoes, as long as I'm properly counseled, I'd probably want to know. I just would like to know. I like to know a lot of things about myself, right? Yeah. So, but I agree. I don't think it's something that should be reflexively sent off on every single person who's not trying to get pregnant.
Right. Okay, this is a good question. If someone got pregnant easily at 35 and 37, would they likely still have good fertility for the third at 39, 40? In essence, does someone with good fertility keep it?
That's a really good question. So I think there is something to be said for people that get pregnant. It means that in subsequent attempts, they're in a different prognosis category, right? Because everything was in working order at one time. But it doesn't necessarily mean you're not going to have issues later down the road because your egg quality is always changing, right? And no one is immune. I have patients who come to me and say, I do yoga, I have the best diet, I take care of myself, I look amazing. And I'm like, that doesn't have anything to do with your egg quality, right?
Yeah. Unfortunately, that was me. I was so healthy and I had no eggs. And it turned out the way it was supposed to with me marrying later in life and starting a family later in life. But, I was a prime example, which is why baby after 35 is here. I had out of 26, it was either 23 or 26 eggs that were retrieved out of 5 cycles of IVF. 16 made it to actually it was more than that. 16 made it to be genetically tested. 1 was chromosomally normal, and that transfer didn't take. And it wasn't my fault. My age was my age, but even though I was healthy, no pre-existing medical conditions, no medications I was on, I worked out. I was a prime example. So, I bring this up because it's a cautionary tale. It doesn't mean it's going to happen to you, but it's better to have more information and be empowered so that you can make more informed decisions, especially if you're anticipating waiting later for that first child or your third child.
Right.
Yeah. Okay, what are the best options for low sperm count? I have already been through 3 IUI cycles at age 40.
So it depends how low, right? There are certain critical thresholds below, especially concentration, meaning the number million of sperm per milliliter of the sample being measured. If it's less than, 5 million, that is usually not going to be something that is rectified with insemination. Because like I said, insemination is just injecting the sperm at the top of the uterus. They still have to swim through the fallopian tubes, and there needs to be enough of them to kind of increase your chance of there actually being a fertilized egg, right? And so with really low levels, it makes sense to do IVF and do something called ICSI, where we inject 1 sperm directly into each egg. With intermediate levels or just borderline low levels, we we can rectify that with insemination because you're concentrating it, you're washing out the dead sperm, and you're getting them closer to where the eggs are being released. So I think you have to look at the entire picture instead of just isolated factors, right? There might be other reasons why it's less likely to succeed. There are other types of sperm tests beyond just looking at the semen analysis as well. And sometimes there's a role for doing that testing. I wouldn't do it on everyone, but looking at other factors like sperm DNA fragmentation, that might push you in one direction or the other. If the levels are high and you have a low count, that might push you towards, okay, IVF is the better way to go, and I don't want to waste time doing IUIs.
Well, also, you could be doing IUI because of a sperm for a reason with the sperm, but at age 40 and 3 IUIs and a sperm issue,
right?
It might be better to just stop the IUI and go straight to IVF.
Right.
Right.
I think a lot of people will fixate on the one abnormal lab they have in front of them and think that that's the reason.
That's the reason why. Yeah.
Right.
Yeah. But again, that's with everything, and we're going to get cut off here in a second. But with everything, it's a big picture. It's not an absolute. It's not one test, one lab value, one condition. You have to look at the entire picture to see what all the players are in the game, if you will.
Right.
Right. Well, thank you so much. Have a great day. I'm so glad we got to do this. I had the rest of the questions. We'll do another live discussion to answer the rest of them. But thank you for taking time out of your day, and have a great weekend.
Thank you. Enjoy your day off.
Thank you.
Talk to you soon. Bye.
Bye.